Hello everyone, this is Dr. Megha MS, working as an assistant professor in the Department of Dermatology, Venereology and Leprosy at Sri Siddhartha Institute of Medical Sciences, T. Begur. We will be learning about a child with hypopigmented patch today. We will go with the chief complaints. A 12-year-old female child from Tumkur comes with the complaints of asymptomatic white patch over the back of trunk for 8 years, and the parents had noticed the patch while bathing the child. We'll go with the history of presenting illness so that we will see more in detail. So the child was apparently normal 8 years back when the patient noticed a small white patch over the back of trunk, which is gradually increasing in size for the past 8 years. Initially, it was a size of about 0.5 into 0.5 centimeter. Now it has increased to reach the present size of 5.5 into 7 centimeter. The patch appeared spontaneously and it was not triggered by trauma. And it was also not associated with itching or burning sensation. There was no history of photosensitivity. There's no history of any topical application prior to the onset of the rash, and there was no other sites involved, because any topical application could also lead to post-inflammatory hypopigmentation, which could be a major differential in this case. And there was no other fever, joint pain, malaise, which would indicate that there is not much systemic involvement or other connective tissue disorders which are associated. And there was no history of pre-existing rash prior to the onset of rash. And there was no history of burns, because post burns also many patients go in for depigmentation. And there was no history of insect bite, and there was no history of indigenous medicine use. What happens is, many a times while the patient has applied some Ayurvedic ointment or homeopathic ointment, there will be a lot of phytocomponents or plant components which can trigger a rash and then develop hypopigmentation, and it is not present since birth, which tells that it is not congenital, and there is no history of hard of hearing or any visual disturbances, which tells that the other systems are not involved. Coming to the past history, the patient's mother has applied an unknown topical medicine from a medical store after the appearance of rash, which showed no improvement, and the patient is also not on any medications currently, and there's no history of tuberculosis, thyroid disorder, atopy, diabetes mellitus, hypertension or bronchial asthma. Atopy and bronchial asthma will be coexisting, but the others show that there is associated disorders and is also required for treatment management. Coming to menstrual history, the patient has not attained menarche yet. Coming to the family history, the child is a product of non-consanguineous marriage. She is a single child, and there's no history of similar lesions among the family members. Coming to occupational history, currently the patient is a student. What happens is, in leather manufacturers or resin company or the ones who are working with phenol components, they will develop something called as chemical leukoderma, which is a very major differential here. So history is important. Coming to psychosocial history, child is studying well and there is no history of social distancing or depression. What happens is, in cases of vitiligo, there is a lot of social stigma associated with it. So it can affect the psychosocial component of the patient. So that should also be considered. Coming to personal history, the diet is mixed, appetite is good, and the child is sleeping sound, and there is no habits. Coming to general physical examination, the patient is well oriented to time, place and person, and she is active. Her weight is about 37 kgs and height about 4 feet 11 inches, and she is afebrile at the time of presentation. Her pulse rate is 86 beats per minute, and her respiratory rate is about 18 cycles per minute. There was no evidences of pallor, icterus, clubbing, cyanosis, koilonychia, lymphadenopathy or edema in this patient. Coming to systemic examination, her respiratory system examination, there was bilateral normal vesicular breath sounds heard. There was no added sounds. And CVS examination, S1 and S2 was heard, and there was no murmurs. Coming to per abdominal examination, it was soft, non-tender, and no obvious organomegaly was seen. Her central nervous system, her higher mental functions were normal. Her ocular examination and auditory examination were also normal to rule out other causes of oculocutaneous albinism. Coming to local examination, here we can see that there is a big solitary depigmented patch. However, there are some islets as well, and which is present over the back of trunk. You can see that there are areas of repigmentation, and this total size was about 5.5 into 7 centimeter. If we can see, the borders are well defined, and the hair and scalp was not involved. The mucosa and nails were also not involved. Coming to our differential diagnosis at present, we could think of two factors such as segmental vitiligo and post-inflammatory depigmentation. We further went on ahead to do other bedside investigations like Woods lamp examination. We could see diffuse blue glow, and on dermoscopy we can see that there is diffuse white background, and there is leukotrichia, that is white hair, and also some areas of perifollicular pigmentation, which will show that there is some repigmentation happening. Since the patient was young, she refused skin biopsy, and for histopathological examination, we were not able to do it. Our final diagnosis was segmental vitiligo. Why? Because in the previous photograph, we saw that the back dermatome was involved, and segmental vitiligo was more preferred based on the history and clinical examination also, because children are more affected, and dermoscopy also, that it shows that it is a stable vitiligo. Coming to the treatment which we gave, it was topical calcipotriol and narrowband UVB therapy, for which the patient responded very well. We will currently go in brief about what vitiligo is. So, by definition, vitiligo is an acquired pigmentary skin disorder which is characterized by loss of melanocytes in the epidermis. This could be of various causes. Mostly, the clinical manifestation would be a well demarcated pearly white or depigmented macules and patches. Macules and patches are flat lesions. Coming to the epidemiology, approximately 0.1 to 2% of the total population is affected, and more commonly second to third decade of life is also more affected. However, there are cases of congenital vitiligo and old age vitiligo are also seen. Coming to pathophysiology, there are various theories. The most common ones are autoimmune theories, wherein there is destruction of melanocyte by CD4 and CD8 T cells. There is neuronal hypothesis, wherein there is neurochemical mediators which destroy the melanocyte, and there is oxidant and antioxidant mechanism, wherein the metabolic byproducts of the melanin synthesis causes cell destruction of the melanocyte, and there is intrinsic defects, wherein there is inherent abnormalities in melanocytes to prevent proper growth and differentiation. One of the common example will be melanocytopathy. And there is composite theory, wherein it can be a combination of more than one. Coming to the most common associations, since vitiligo is also an autoimmune disease, other autoimmune diseases are also most commonly associated, like alopecia areata, which presents as bald patches over the scalp. Pernicious anemia, we know that it presents as vitamin B12 deficiency, and type 1 diabetes mellitus, Hashimoto's thyroiditis, and other autoimmune conditions of the skin, including connective tissue disorders, are also very common. Classification of vitiligo is a bigger arena, wherein Mostly we divide into non-segmental, segmental, undetermined classification. In the non-segmental vitiligo, it can be acrofacial. That is, there is acral parts involved and facial parts involved. It can also be generalized or universal. Universal wherein there will be near complete or about 80 to 90% of the depigmented skin is seen. It can be mixed of both, or it can only be mucosal. That for an example, only lip, only genital mucosa can be involved. And in segmental vitiligo, it can be involving only one segment, that is unisegmental vitiligo, two segments, that is bisegmental vitiligo, or multiple segments such as plurisegmental vitiligo. Others such as undetermined or unclassified vitiligo, it could be focal vitiligo wherein only a depigmented patch can be seen. Again, other rare types are vitiligo minor, punctate vitiligo, and follicular vitiligo. Coming to VIDA score, that is vitiligo disease activity score. This is important to assess if the patient is, if the vitiligo is stable or not. So we would suggest, also tell if the vitiligo patch is increasing in size for more than 6 weeks or less, then the +4 is given. If the vitiligo patch is active for 6 weeks to 3 months, then +3 is given. If it is active, the vitiligo patch is active for 3 to 6 months, then +2 score is given. If it is active for 6 to 12 months, then +1 is given. If it is stable, it is deemed stable only if it is not increasing in size for over 1 year or more, then score 0 is given. If at all it is stable and there is spontaneous repigmentation within the patches, like we saw in the dermoscopy earlier, then it is deemed -1. So why is this important is, if at all there is some stable vitiligo, we can take them for surgery only if the stage is at 0 or -1. Then many people forget the psychosocial aspect associated with vitiligo, because vitiligo lesions on the visible area will lead to severe cosmetic disfigurement, and it is also a source of considerable psychological stress, particularly in dark skinned individuals, because there is a lot of contrast and it is very much visible. And as we already discussed, now vitiligo is just not a patch, just not a skin inflammatory condition, but also a much beyond systemic condition. So coming to the management, there are many multiple management modalities, but we'll have to personalize it. So how do we personalize it is depends on the type of vitiligo. Say mostly segmental vitiligo, which happens in children, it tends to become more stable earlier. So surgery would be a better modality, and it is very resistant for topical treatment. And also distribution and extent of involvement. If it's a focal vitiligo, then topical creams would be good. If it is a generalized vitiligo, then oral immunosuppressants should be given. Then coming to the disease activity, if it's stable or progressing, also will make a big difference. And associated psychosocial economic status of the individual and the concern for the patient towards the disease is also very paramount. And also easy availability and accessibility and acceptability of appropriate treatment options should also be considered. Coming to the most common topical therapies that we give for vitiligo are corticosteroids and calcineurin inhibitors such as tacrolimus and pimecrolimus, and vitamin D3 analogs. And phototherapy such as narrowband UVB therapy is the preferred gold standard for inducing repigmentation, because it also causes apoptosis of the T cells and also aids in repigmentation. And other systemic treatment, the most common ones would be oral steroids, that is betamethasone or methylprednisolone. Oral mini pulse can be given, and cyclosporin and methotrexate are also very good treatments for vitiligo. Surgical options are mostly reserved for stable vitiligo with lesser body surface area involvement and those are varieties including tissue grafts to tissue free grafts, including NCS, that is non-cultured epidermal cell suspension, Jodhpur technique and melanocyte culture. And there are various emerging treatments for vitiligo such as JAK inhibitors, even topical ruxolitinib is good, and afamelanotide is also good, and oral JAK-STAT inhibitors are extensively used now. The most common examples are baricitinib and tofacitinib. Coming to summarize, vitiligo, as we saw, it is not only skin, it is a systemic disease and it requires multidisciplinary care. We should all collaborate with ophthalmologists, ENT surgeons, physicians and psychiatrists for overall treatment of the holistic treatment of the patient. Thank you.